Make sure you have adequate surgical margins, and previous speakers have spoken about it already. Sometimes you get an R1 resection, but they may be acceptable. Sometimes you don't get a local recurrence. Now, the next thing is you reconstruct it. Basically, whatever defect you have created from your resection in order to get rid of the cancer, just reconstruct it. It may be soft tissue, it may be vascular, you may need to do a functional one, it may be bone and joint, or it may be what we call composite. Just reconstruct what you do it. I mean, the whole meeting was about reconstruction. We know how to do that very well. So it's how to marry the two of them together, which is what we want to talk about actually for this particular conference. Soft tissue coverage, we know we want to do like for like. The only additional thing you want to think about is, what's the effect on the margins? Can you use a local flap? And of course, the second thing is, what's my adjuvant treatment going to do? Radiotherapy, chemotherapy, is it going to affect my flaps? So something like this, you do a radio forearm flap, it was ulcerating, doesn't heal so well, but heals eventually, quite straightforward. Again, we are reconstructive surgeons. Now, you take it a little bit a step further. You have a big melanoma, get rid of it, and then you find out, oh, I've got nodal disease, you do an en bloc resection, but basically, something that we know how to manage once we get the cancer principles right. How about vessels? Again, we do this in the middle of the night, nothing too difficult for us. In fact, upper extremity vascular reconstruction and the results of it probably much better than in the lower extremity. You spare a thought for the ischemic bypass segment, what's going to happen to it, because when over time, if you radiate your revascularized, resected and revascularized limb, you're going to get lymphedema, and then you're going to get repeated wound breakdowns, which you have to just anticipate and manage if your patient survives. Now next, functional reconstruction. It can be motor reconstruction in the form of tendon transfers, muscle transfers, nerve transfers. Then we don't talk about sensory reconstruction so much, even if you go for the brachial plexus symposia. But how do you restore sensation also? Because if your patient's a survivor, they need to feel something. So tendon transfer, just a case example. Straightforward soft tissue sarcoma with resection of the radial nerve. With tendon transfers, you get a good result. Something a little bit more complicated where the median nerve is involved. Get an adequate resection. Then after that, reconstruct it in a mixed way where you get sensory reconstruction through a nerve transfer, tendon transfer for motor reconstruction, and you can get a fairly good result. And this patient is now, I think, 9 years post-op, and Chong Ming actually wrote up this patient a few years ago. So the principles of reconstruction we are familiar with, and we are the ones who can actually help sometimes the ablative surgeon to manage this. Sometimes we are the ablative surgeon, so that's an advantage for us. How about bone reconstruction? We can sometimes put in a prosthesis, or we can do biological reconstruction. We can use vascularized grafts. We can lengthen, we can use an allograft, or we can recycle the bone, which you can recycle using heat, cold, or radiation, which is what we like to do more here in Asia, because we don't tend to have such a good allograft bank in general here. Of course, I need to mention Professor Robert Fo, our Tajima lecturer, who pioneered this technique of an autoclave bone graft, bone marrow, and a vascularized bone graft. He came up with this 40 years ago, and I'm actually getting to see his 30-year follow-ups, and they are durable, they do work, and the patients have gone on to get married and have children. So I actually have the benefit of seeing his long-term follow-ups 30 years later. Now, amputation replantation, if we can do a hand transplant, if we can do a major limb replant, we can do this too. And it can be done for some patients. In the upper extremity, we're comfortable doing that. How about the lower extremity? And then when I was actually doing my research and trying to find out, oh, maybe you can try being the first, I find out that Prof actually did this 40 years ago also. Amputation, replantation of the lower limb for malignancy. Do we still do amputations? Yes, sometimes we do. When, your resected and reconstructed tumor ends up being worse than an amputation, that's when we will still consider doing an amputation. Now, how about this fungating tumor here? Looks like it's going to be a hand amputation, or at least a triple rate, because we've still got the thumb there. Thankfully, biopsy showed squamous cell carcinoma. We just radiated the patient and we saved the hand. So the point being that, as Chung Mei has mentioned, and Sophie and all the previous speakers have mentioned, know your diagnosis, know what treatment options are available. Another example, the registrar who was on call then and took this photo for me is now in the crowd here as a consultant. This fungating tumor, which naturally would be, it's malignant, and you know that this will require an amputation most of the times, turned out to be a B-cell lymphoma, and you just give radiotherapy and chemotherapy. The patient's now 7 years post-treatment. You can see the bottom, this thing was actually 2014, so it's, 7 years. Of course, surgery is required to debride the limb. It's not the best function because a lot of it was destroyed from the cancer, but know your cancer, know what the treatment options are, decide what's the best treatment for the patient. Surgery is often required, sometimes it's not required, and do the right surgery first. Get rid of the cancer, then let's talk about reconstruction. So in conclusion, limb salvage can be performed for most patients with upper extremity malignant tumors. The objective is control the cancer first. No point having a beautiful reconstruction when the patient gets a recurrence within 6 months and passes on. We can reconstruct everything, we know that. And we should be involved in the care of the patient from the word go. Preferably, we be the ones doing the resection too, because we understand oncology. And finally, don't discount amputation, sometimes that's required. Thank you very much.